The workup of unconjugated hyperbilirubinemia in the neonate is quite complex and can be frustrating to learn. But once you comprehend the rationale for each investigation, you will be able to grasp contemporary algorithms with less difficulty. It is the aim of this lecture to help you organize vital information in your mind to help you conceptualize the strategic approach to evaluating these patients. Now, because algorithms can vary depending on location, please be sure to refer to local guidelines. Before considering any investigations, remember that it is important to take a careful history and to perform a thorough physical examination, which may reveal risk factors for the development of severe hyperbilirubinemia or provide a hint as to the underlying mechanism. When it has been determined that we are indeed dealing with an unconjugated hyperbilirubinemia, there are 5 or 6 tests that are commonly ordered. An antiglobulin test, also known as Coombs test, either direct or indirect will do, a reticulocyte count, a complete blood count, a peripheral blood smear, and the blood type and Rh status. Other tests may also be warranted, especially a G6PD assay. These tests are not necessarily ordered all at once, but altogether, the combined results of these investigations will help you narrow down the differential diagnosis. Now let's take a look at the most common etiologies of unconjugated hyperbilirubinemia in the neonate. Hemolytic disease of the newborn occurs when there's an incompatibility between maternal and fetal blood types, most commonly ABL incompatibility and rhesus isoimmunization. This etiology can be identified with a positive direct or indirect Coombs test. Now the other tests have usually already been ordered, which could reveal decreased hemoglobin level, reticulocytosis, and microspherocytosis. These findings are suggestive, but are not pathognomonic. The presence of spherocytes in particular is transient and will diminish over time, unlike with hereditary spherocytosis in which it will persist. 2 intrinsic causes of hemolysis include red blood cell enzymopathy and membranopathy. Both could cause a decreased hemoglobin level and reticulocytosis, just as with hemolytic disease of the newborn. However, the Coombs test will usually be negative. With the red blood cell membranopathy, there are also often abnormal findings on the peripheral blood smear, such as spherocytes or lymphocytes. Certain tests can then be used to confirm a specific condition. For example, the EMA binding test can confirm the diagnosis of hereditary spherocytosis. With erythrocyte enzyme defects, red cell morphology could yield nonspecific findings. For example, with G6PD deficiency, the peripheral blood smear may reveal bite and blister cells. However, specific enzyme assays can confirm the diagnosis of G6PD deficiency and other enzymopathies as well, such as pyruvate kinase deficiency. Hemoglobinopathies may also occur, but are less common causes of intrinsic hemolysis. Polycythemia is associated with elevated hemoglobin, and these infants are often plethoric on the physical examination. A few potential etiologies to consider include twin-twin transfusion, maternal-fetal transfusion, delayed cord clamping, and macrosomia in infants of diabetic mothers. Significant extravasation of blood can occur with extensive bruising or sequestration of blood within a closed space, such as with a careful hematoma. Investigative studies may not reveal specific findings, but physical examination could point you in the right direction. At times, however, the location of blood extravasation can be less conspicuous, as may be the case with an adrenal hemorrhage or a subdural hemorrhage. Lab findings can also be highly variable with infections in the neonatal age group. Because of the possibility of severe morbidity and even mortality, there should be a low threshold for further evaluation and management. This last section includes a myriad of conditions. The common factor between them is that with the exception of hyperbilirubinemia, these initial aforementioned lab tests are unrevealing. I've grouped them here all together because after ordering the initial battery of tests, you will likely have excluded a hemolytic disease process and can now either diagnose a benign condition or continue investigating for a pathologic entity. Determination of the etiology requires deduction based on findings from the history and physical examination and, if necessary, further testing. Decreased bilirubin clearance, increased enterohepatic circulation, and or other factors may underlie the indirect hyperbilirubinemia in these patients. The first 3 etiologies to consider are breastmilk jaundice, Lactation Failure Jaundice, and exaggerated benign neonatal hyperbilirubinemia, also known as physiologic jaundice. There can be quite a bit of overlap between these conditions, but the history and physical examination may help to distinguish between them. For example, the infant with breastmilk jaundice usually presents after the 4th day of life and will be thriving, while the infant with lactation failure jaundice typically presents in the 1st week of life, but not during the first 24 hours, and may be dehydrated with weight loss due to insufficient caloric and fluid intake. With benign neonatal hyperbilirubinemia, an exaggerated and prolonged course of physiologic jaundice may occur in babies with risk factors such as low birth weight. Decreased bilirubin clearance can occur due to a few different genetic disorders such as Gilbert syndrome and Crigler-Najer syndrome, and when there is suspicion, genetic testing can be used to confirm the diagnosis. A few other conditions may also decrease the clearance of bilirubin, such as maternal diabetes, congenital hypothyroidism, and galactosemia, and additional testing is based on supporting findings, such as thyroid function testing for hypothyroidism. Impaired intestinal motility, infrequent stooling, and potentially breastmilk jaundice can result in increased enterohepatic circulation of bilirubin. When the etiology is not clear following the history, physical examination, and these investigations, then further workup may be required. For example, an enzyme assay may help elucidate the diagnosis when the red cell morphology is normal, Coombs test is negative, but the reticulocyte count is high. When infection is suspected, then a septic screen is paramount. But for the most part, these few tests, along with a skillfully taken history and physical, will lead to an accurate diagnosis in the majority of cases. I hope that this very brief lecture has helped clarify a topic that, for me at least, is very complicated. If you would like more information on specific conditions, such as breastmilk jaundice, or other related topics, look for other lectures here on our YouTube channel, Medical Education for Visual Learners. I hope you found this lecture to be helpful and worth your time. Please feel free and very welcome to leave a comment or suggestion below. And if you like this video, please hit subscribe and check out some of the other videos in this channel.